Hi, everyone. Welcome back to Arthritis Consumer Experts Arthritis at Home program. My name is Cheryl Koehn. I work at ACE. I'm also a person who's been living with rheumatoid arthritis, what seems like forever now. And I'm really, really thrilled to be joined with me today by Dr. Michel Zummer, who is a practicing rheumatologist in the province of Quebec. Dr. Zummer and I have known each other for a very long time. He has been very gracious with his time over the years, participating in ACE programming. He's a professor of medicine in the Division of Rheumatology at University of Montreal, and he is a past president of the Canadian Rheumatology Association. He's also been someone that has led Canada in the area of models of care in arthritis, specifically inflammatory arthritis. So we're really happy to have Dr. Zummer with us. Thanks so much, Dr. Zummer, for joining.
It's a pleasure to be here, Cheryl.
I mentioned in my intro, Dr. Zummer, that you've been very, very involved over the years in the development of models of care specific to inflammatory arthritis. And I'm wondering if you can share with our audience sort of where that body of work that was, I think, originally done in the Arthritis Alliance of Canada, and it was up to basically each province to take the work that was done sort of at that overarching model level, national model level, and implemented in the provincial healthcare system. So just wanting to get a bit of an update where you feel you are, what's going well for you, what can be improved, and where you hope to see things. Just wanting to get an update from you about models of care and inflammatory arthritis in the province of Quebec.
Yeah, thank you, Cheryl. I think a lot of what's been done has been more bottom up than top down at the provincial level. We've been able to get through with the government has been very, very frustrating. So from the bottom up level, we've been sort of trying to create teams with allied health professionals, physiotherapists, occupational therapists, which has not been that easy, but certainly they're being more and more incorporated into our practice, as well as nurses. So nurses have been, again, a bigger part of our practice, but there's been no sort of formal type of input from the government. There has been some activity that's been on and off for the last few years at the provincial association level with the Ministry of Health. As far as provincial level, for all the specialties, is having a centralized triage and referral process. So every specialty has its own triage form, and the province is divided into 9 regions. So for instance, I'm in Montreal, so this is the Montreal region. So now we have a centralized intake that comes from primary care. This is only from primary care, not from other specialty care, and based on a form that's been done, and it's only sort of paper triage, and then it's sent to wherever rheumatologists have made themselves available. So in theory, this is very good. Wait times can decrease. However, we've had issues with the actual triage paper and the way it's been filled out by primary care. I've asked repeatedly, is there any sort of evaluation can be done of the process or whatever? And there's been no attempt to have any type of formal evaluation of the process and to see how we can improve the process. So what is true is that, if you have the right information, the patient gets prioritized properly, then somebody with inflammatory joint disease will be able to see a rheumatologist within 3 to 4 weeks. And the patients that I see that have been triaged properly do get to see us, and usually within the same region. And of course, there's disparities. If we're in a region where there's very, very low percentage of rheumatologists, then there it could wait longer. And it's very rare that patients get referred from one region to the other, but certainly in the areas surrounding Montreal, some patients have been referred in. Yeah. So, and the other issue that we have in as far as following and trying to coordinate care is electronic record keeping, where we have no good electronic record keeping
That
and
was
no
my next
communication.
question. How do you do this without EMR?
Well, we're still using fax machines. So yeah, we are still using fax machines in Quebec, and the email apparently for some sort of security reason has not yet been approved by the government. So really formalized type of email, not especially before the pandemic. With the pandemic, there's been more latitude, and I know we're probably going to discuss this later on,
Yeah.
but we can have a little bit better communication with electronic media. But for now, it's really quite frustrating that we're still, well, we get our notes and our charts scanned. We don't have any real electronic record keeping. So we do have access to more information. There's a government website where we have access to imaging, lab results, and medications. We don't have any information about other visits and other specialties unless it's in our own institution.
Yeah, and I mean,
So I feel we're still pretty far behind, and implementation has been very difficult.
I'm listening to you, Dr. Zummer, and I'm thinking, well, what can ACE do? What can other advocates in the community do? And as you say, this work has taken place the bottom up. And what we need is the top, meaning government, who makes the policy, to come closer to you on the ground and help you get these things sorted, so that in a model of care, when the very first point of it is, let's say, for example, me thinking, hey, this swollen joint's not normal. Oh, now my knee is swollen a week later. Now it hurts to walk on the balls of my feet. Those are classic signs and symptoms of an inflammatory arthritis. And so that's me being aware of a symptom is one thing, then getting into you for a proper diagnosis is another. And then of course there's medical management, like what are you and I going to do to build a treatment plan? And then there's that box that says, oh, well, there's got to be all this interdisciplinary care. How do you communicate with the nurse, the physiotherapist, and all of that? And then how at the end of that spectrum, which is really, I view a model of care as a circle, how do I do best on my own out in the community once I'm on a good treatment plan? So just as a bit of a diagram describer for our audience, it sounds like you've done a yeoman's work there, but I am distressed to hear about the lack of parallel progress maybe on the EMR, on the electronic medical records front, because without those, it's really tough.
Yes. We went through a hard period like 2 health ministers ago. We went through yet another transformation of our healthcare system, and it was extremely top down, where there was very little individualization for the type of specialty, and really no input at point of care. So that made it very difficult to actually implement changes.
Yeah.
And we changed health ministries and ministers and whatever. And then, COVID hit. So everything seemed to have stalled. But certainly, we're hoping to come out at some point out and try to, restart and reconnect with government and try to have policy that would help healthcare for our patients. And that's very important.
Well, we look forward to that conversation heating back up, and we'd be very happy to be a part of that with you as always, Dr. Zummer.
Yeah, when we every time we have gone to government, we have gone with our patients and try to always bring the patient's view into government to know what really is important when we're talking about change in the system.
Yeah, and it's so important to have not just that lived experience in the room, but it is the moral authority from the disease perspective, is the person living with the disease. Now, you mentioned the medication management part and formulary management part on the part of government. Tell us how you view, that we publish a report card which ranks provinces and their performance on evidence-based availability and cost-effectiveness availability of the medicines that you really rely on to get people like myself's disease under control. And Quebec last year in 2019 ranked in 4th place on our report card, and you'll be happy to hear that they will move up two ranking points in this year when we publish near the end of the month. And so I guess I'm looking, but where they still lag are the things that are under review. So not only is there a queue waiting to get to people like you to diagnose us and to treat us, there's a queue when it comes to medication listing on provincial formularies. So Quebec isn't alone in this, of course. So I'm just curious to know, from your perspective as a rheumatologist, do you feel you have what you need when you need it to prescribe based on how the government puts its formulary together and the criteria that patients have to meet? Where do you think there can be improvement, and where do we really want to applaud government for doing a good job?
Well, yeah, and I'm glad you said that, because I always thought that our patients in Quebec were very fortunate.
Yeah.
Because of, first of all, the law that was passed many years ago where everybody must have drug insurance in Quebec. So if you have the possibility or access to a private plan, you go on the private plan, and if not, you default onto the government healthcare drug plan.
Right.
And the private plans have to give you minimum what the government plan gives you.
Oh, okay.
That is important since it limits the amount of copay and puts a ceiling on drug costs for the year, and a bit of it is based on income. So really, financially, I think it's not a stress. And for us, knowing that everybody has some form of insurance, we never have to think of, do you have insurance or not? And most often, the criteria for the private plans and the public plans are pretty much identical. Our drug plan in Quebec, one thing I was very happy was that I always felt that any patient of mine that I thought that needed advanced therapies would be able to get it. And I thought the criteria were pretty fair as far as the initial criteria, what drugs we would have to try before. And we also have another type of request form where if you don't fall into the criteria, but there's a special situation, we can make a special request, and that would be considered independently. So I think, everybody that needs a drug can get a drug that we want to prescribe. All approved, and like you said, there is a bit of a lag, but most of the drug classes, almost all of them, are pretty much available. Where the problem is the paperwork, which is a big burden. It's a burden on us because it's quite extensive paperwork, and to do the initial request, we have to reevaluate the patient 5 months later to make sure that there was an improvement. And then we have to do an annual review and an annual submission for the patient. So it's the paperwork that binds us down. A lot of it's done by fax, but we can do submit electronically to the government. And the turnaround times are pretty good. It varies, but I would say you're between 2 and 4 weeks waiting for approval.
Yeah, that's not bad.
Yeah, and that's usually the time that we need to do all the testing that we have to do prior to prior to our patient starting the drug. So it's really not too bad. So I think on balance, I think I'm pretty happy, because I think any of my patients that would need an advanced therapy would be able to receive it.
When you say advanced therapy, you mean the targeted small molecules or a biological
Correct.
medication? Yeah, okay.
Correct.
Well, that's really good news, and I must say that's reflective of what our report card says as well. I think that every province can improve. Every province can do a little better in terms of turnaround time. And I don't think provinces, it's been, we've been tracking provincial performance in this area, I'm going to say well over 15 years now. And I think the one thing that is often lost on people in the provincial government formulary management systems is how much time you do take with your patients. First, to talk to them about the range of choices that are available and come to a decision, but also then all of this unending paperwork. I know some provinces required a touch point 3 times a year, if you can believe it. The province of British Columbia has done a good job, I think, streamlining some of those things so that people who are good at that first year won't need annual renewal forms. You basically have to fill out the hack to show that you're continuing to do well on the therapy. So that's really good news. Thank you. It's always great to talk about something positive when it comes to things that the government is managing.
It certainly makes a lot better for our patient and a lot easier on the physician as well.
Yeah, for sure. Really, Arthritis at Home was created to meet people's needs, to deliver information in a more substantive way than just sitting there reading something on a screen. We wanted people to see people like you who were out there on the front lines, figuring out ways to still manage their patients and give high quality care. And I guess I'm just curious, and so is our audience, what's it been like in Quebec? We know that right now, today we're speaking, and I was just listening to CBC, and I heard that both Quebec and Ontario cases have really kind of gone through the roof in the last several days. What's your experience been so far? I know that many provinces have implemented virtual care platforms and a way for you to actually deliver care via the internet or by telephone. How has that been for you and your patients, and what do you think can be improved? Because I don't think it's going away, right? This type of care probably was needed long ago for people who live at great distance from their rheumatologist, or maybe have mobility concerns. Like, there's a lot of what I do with my rheumatologist that can be done like this.
Yeah.
So I'm just curious to get your views about what's happened in Quebec and where you see yourselves at today and going forward.
When COVID hit, obviously we shut down, like all across Canada. Our hospital was designated a COVID hospital and eventually became like almost 100% COVID. Our outpatient clinic was closed and we were not allowed to see any patients at all for a long time. Some of our younger rheumatologists actually went and worked on COVID units, and even some physicians were called to work as allied health and support, and certainly some even went in the long-term care institutions where the disease was really quite prevalent. So everything closed down, and the government gave us the right to the authority, I guess, to have telerheumatology or telespecialty to be able to call. So right away we changed and we started doing all our appointments by phone and for the hospital. Now, I also do 1 day of office outside the hospital. At the beginning, we were closed for a couple of weeks till we realized how to deal with the sanitary issues, and then opened up the office with all the protection and whatever. But as far as the hospital goes, whereas the bulk of my patients and all of my patients that have inflammatory joint disease are followed at the hospital. So at the beginning, we were doing telerheumatology. Everybody was at home. We were at home. They were at home.
Yeah.
So it was very easy to connect, the appointments and everything else. We were faxing all the prescriptions to the pharmacies, directly to the pharmacy. So I was at home. I was, sending back my PDFs by email to my secretary, who would actually print them out and fax them to the pharmacy. So what's with that.
Yeah.
And so that lasted quite a long time. My patients that had to be seen, I was one of the luckier ones because I do have the office, and I would have them come into the office. So patients that really, flared their disease and needed injections or whatever had to be examined, because rheumatology is great, video, but it's hard to actually examine the joints by video. And we were just basically doing telephone. So we were thinking of, we were also given a platform, a platform to do video visits. However, the problem with that is that we had zero support to actually set up the appointments and to connect with the patients and how get the appointments settled and prepared and coming back. So in the last month or two, there's been a pilot project at the hospital for outpatient care to do more video. We've had a separate screen installed and microphones, and we do now have a pilot project with one of our rheumatologists, seeing how it is the planning. So the actual video part is not that much of a problem, except that I hear that a lot of the patients' cameras are not that great for
Yeah.
definition, and
Yeah.
it's hard to really see things. Basically, I'm doing only telephone. I'm not doing any video, but I've gone back to almost 100% 100% in-person visits right now, because the other thing we found doing telerheumatology is good for maybe one or maybe two visits, but at some point we do have to see the patient and
Right.
examine the patient. So, a lot of things, like you said, can be handled over the phone, but at some point we do have to examine. Now, we talked about medications like biologics and targeted small molecules. Patients were given an automatic extension by the government so that they would not be reviewed. But now we have that backlog, and now we have to see them because we have a deadline now to review the patients.
That's like, I'll do homework tomorrow, but then tomorrow shows up and you got to do it.
That's right.
Yeah.
So I think, for the most part, the problem was our nursing staff got shifted to COVID care, and we had no consistent nurse. So there's 8 rheumatologists in our divisions, and we had a lot of phone calls. And again, our technology was that our answering machine could only take maybe 15 calls, and we could not expand it. The other thing, as you might know, and I'm sure you know, is the hydroxychloroquine story in Quebec, where the government decided to put in an order that everybody on hydroxychloroquine would stop, except for lupus patients, pregnant patients, and patients with juvenile arthritis under 18.
Yeah.
So it was a prescription that was sent off to all the pharmacists. The pharmacists were supposed to stop the drug without contacting the rheumatologist, and give the patients information that they should contact us if they start being symptomatic. However, normally, as you would expect, a lot of patients did call, and we were flooded because we have thousands of patients in our division that are on hydroxychloroquine.
And you guys have taught us to be compliant, to be adherent to our medications.
You better believe it. That's right. So they're being stopped. And not only that, but again, the faxes were coming in for the pharmacy saying, we're going to stop the hydroxychloroquine. What are you going to give them instead of that? Which was not what the government said. So that lasted for about 6 weeks. A lot of, patients that I knew, patients that were on only hydroxychloroquine that would call, we had the ability to prescribe it and say that this patient really needs it. So patients that called me that were only on hydroxychloroquine, I automatically renewed them, and they got it despite, but they had to call to let me know, because I don't have EMR, so I couldn't find my patients that were on the drug, right? And patients that had previously tried stopping it that I knew were that they knew they would flare, they called up and we got it to them. So that lasted about 6 weeks in all till this got straightened up with the government. And then what happened was that some patients were not called by their pharmacists at the end to tell them that the drug was now available, and they were not restarting their drug. So there's a bad communication problem.
Yeah.
So we had to go through that, but that's settled now. So we went through quite a hard time dealing with the actual volume of calls with inexperienced nurse that didn't really know rheumatology, and trying to manage all that. So there's a bigger burden put on the rheumatologists, in addition to some of us that were covering for our fellow rheumatologists that were actually doing the COVID work in the hospital or even outside the hospital.
Yeah, I tell you, I just don't know how you guys have managed through all of this. It is an amazing feat, in my opinion, and I doubt anyone works harder than our rheumatology community for its patients. We just love you guys for all the reasons you've just pointed out, all the fighting that you do on our behalf. This thing with hydroxychloroquine, we were well aware of it. We had many members call us asking us how to, what can they do. ACE was part of a group of other patient organizations who advocated to the federal government to intervene, which in fact did happen. And we're glad that worked out, but so sad to hear that you had that layered on top of managing COVID and trying to figure out how to run your rheumatology office at the same time. So I'm glad to hear that that's resolved. But I just want to thank you so much for everything that you're doing for your patients there. And this goes beyond, obviously beyond you. I'm thanking your entire community of rheumatologists in Quebec and all of the allied health professionals that toil away helping people like myself. It's really a wonderful thing. So thank you so much. We are going to come back and knock on your virtual door again, and we will have an interview with you en français.
Well, thank you very much.
Yeah, no, it's been super. So thanks again. Please be well. I hope your family's staying safe, and we'll talk again very soon.